Engage Your World has a very simple goal: to bring scholars and practitioners of matters of global importance to FSU. The hope is to learn more about the world around us, recognize opportunities to learn from each other, and discuss creative solutions to complex problems. This academic year, we will be focusing on matters of global health and social justice. These are both very timely subject matters. And to kick off our series this fall is Dr. Alan Rowan from the FSU Public Health Program. You might be wondering why we are starting right at 5 o'clock. And it's because Dr. Rowan has some really important and informational dialogue to have with us with regard to how epidemics become pandemics. Before we do that, however, I want to tell you a little bit more about Dr. Rowan. Dr. Rowan has a 25-year experience or trajectory in health, which is not just extensive, it's immensely impressive as well. He started out as an emergency medical technician in the emergency rooms and proceeded to work for clinical trials branch of the National Institutes of Health in Washington, D.C. Within the Florida Department of Health, where he has been for over 16 years, Dr. Rowan has served in several roles. He started out at the local health department, worked as an epidemiologist in Northwest Florida counties, coordinated the birth defects registry, pesticide and lead programs, and led the creation of the Florida Epidemic Intelligence Service, as well as the Aquatic Toxins program. He also served as the director for the Division of Health, Access, and Tobacco. With several decades of work in this field, Dr. Rowan brings his energy and acumen teaching courses in epidemiology, environmental health, infectious disease epidemiology, and comparative international health at Florida State University. Without further delay, I would like to turn over the spotlight to Dr. Rowan. Let's welcome him with some electronic applauses.
Sure. Well, thank you very much for the invitation. Thank you for joining us for this relatively brief discussion about pandemics and kind of how we got to where we are now with past pandemics and then the current COVID-19 pandemic. And hopefully I'll be able to answer your questions afterwards about infectious disease in general, pandemics, and perhaps this one specifically. Next slide. I thought we'd start out with some simple definitions. Next slide. Thank you. I thought we'd start with some simple definitions about an epidemic. You hear that term a lot, and an epidemic is just simply a disease rates that are higher than expected, similar to an outbreak. And then a pandemic is simply when that epidemic is on a global perspective, usually multiple geographic areas or countries. And this seems pretty simple and straightforward, but often it can be kind of confusing and fairly complicated. An example of that might be HIV/AIDS, which is certainly a pandemic, but the World Health Organization calls it a global epidemic. Another example is cholera. We are currently on the 7th cholera pandemic. Some examples of that more recently is the 2010 earthquake in Haiti. Some relief workers came to help out, and Haiti did not have any cholera as part of that country prior to that, but following the relief workers' arrival, they have now they have cholera, and over 10,000 Haitians have died from that. Next slide. So you see here, and I'm going to come back to this slide later, but right now you see a list of past pandemics. Now, even a list of pandemics can be controversial, but this is a list that pretty much everybody agrees on that were pandemics in the world past. I want you to look at this and see if you can see what all of these pandemics have in common. And I'll give you just a second to look at that. What do these have in common? The answer is all of these are what we call zoonotic diseases. And a zoonotic disease is simply a disease that transfers between humans and animals and back and forth. Usually it's a reservoir in animals that then people can catch. And this is certainly what we're doing right now with COVID is a good example of that. Let's go to the next slide if we could. So again, look at these. You'll recognize a lot of these diseases. What are these diseases? What do all these have in common? Well, it's the same thing. They're all zoonotic diseases. In fact, 6 out of 10 diseases in humans are zoonotic diseases. They're passed, again, from animals to humans. And if we look at some of those, I just grabbing some, but you've heard of Lyme disease, certainly, plague probably, rabies, of course. And I'm happy to talk about any of these that you want to talk about later, but these are all some of the more serious diseases, and they're all have a reservoir in animals, and then occasionally what we call a dead end host, when they come to humans, and it can have very deleterious effects among us. Next slide, please. What you're looking at here is on the left-hand side, the left column are the top zoonotic diseases of 2019 as considered by the Centers for Disease Control and Prevention, or CDC in Atlanta. And again, these are ones that we're going to talk about several of these today, but zoonotic influenza, like avian influenza, swine flu are examples of that. Salmonellosis, you'll see that with, of course, foodborne outbreaks. West Nile virus arrived in Florida in 2001, and within a year covered the entire United States, including Alaska and Hawaii. And of course, SARS and MERS in 2019, and then now 2020, we would include COVID-19 to that as well. And many of you have heard about Lyme disease and maybe have some experience with that. I'd like you to look at the column on the right, if you would, the special zoonotic diseases category A. What do those diseases have in common? They are zoonotic disease, but what else do they have in common? Well, these are all top bioterrorism agents of concern in the US and indeed the whole world. These are the ones that we're most concerned about, and they are, by the way, not coincidentally, zoonotic diseases. I'd love to talk about, I'm fascinated by all of these, but just take the top one, anthrax, as an example. All of you are familiar with 9/11. You know, we were attacked September 11th, 2001. What a lot of people forget is that same month, September, and then the following month of October, many envelopes full of anthrax were mailed across the primarily eastern side of the United States. And it first detected in Florida, in Palm Beach. We had a gentleman that worked at a multimedia company, died of anthrax. And it was a great, of course, a public health concern. And I was assisting, helping, looking into that, why that occurred. And so it was a public health issue until his coworker also became ill with anthrax, and then it immediately became a criminal investigation headed by the by the FBI. They took that over, and we ended up having 23 letters. And 23 people become sick from those letters. Currently, well, and also plague down there is important. One thing I want to point out, though, that you don't see on that list on the right-hand side is smallpox. Why isn't smallpox on there? Well, you might say, well, one, we've eradicated smallpox, and that's certainly true. And that's what I want to talk about some. Now, smallpox was a horrible disease. Hundreds of millions of people died. Certainly tens of millions have died from smallpox just in the New World, North and South America, back in the 1500s and 1600s, the Native Americans. But the other thing I want to point out with smallpox is it's not a zoonotic disease. And what that means is it's only transmitted from humans to humans. And so once we were able to vaccinate humans against smallpox, we were able to eradicate the disease. If it had also been in animals, it would have been much more difficult to eradicate smallpox. And in fact, the last wild smallpox case was in Somalia in 1977. The following year, there was a case in a laboratory in 1978, and it was declared eradicated in 1979. We've not had any smallpox cases since then. Currently, we only know of 2 places where smallpox resides. It's in a lab at CDC in Atlanta, another lab in Russia. We hope that's the only places it currently lives. Next slide, please. Okay, we're back to this list. I do want to run through these kind of quickly. I think they're interesting, and I also think they'll educate us about kind of where we are now. The first one is Black Plague. You've probably all heard of this. Mortality was probably half of Europe died from this. Perhaps 75 to 100 million people died in these years from Yersinia pestis, or the plague. Bubonic plague, it's also called. Now, just quickly, briefly, it's passed as from fleas on rats and dogs to humans, and it's transmitted that way. Some other interesting things about this. This is where the term quarantine was first used. Quarantine is an old Italian, or specifically a Venetian word meaning 40 days. And that's how it worked. So a ship would sail into port and would put up its Q flag, or its quarantine flag, and would sit in the harbor for 40 days, and nobody could get on the ship and no one could get off the ship for 40 days. At the end of that time, they would row out to the ship, and either everyone would be healthy or everyone would be dead. And that's how they would keep diseases from then spreading to Venice and to other Croatian, other places at that time. Quarantine, versus what that means is keeping people that have been exposed away from other people. Isolation is when a person already has a disease. Now, so it was 40 days quarantine, which is better than what we have now for COVID, which is, of course, 14 days. The next one is Spanish flu. Hopefully you've heard about this. 1918, 1920, Spanish flu. It probably started in Kansas with a bunch of pigs, probably. The H1 is a designation for the proteins on the outside of the virus. Hemagglutinin and neuraminidase, or the H and the N. And mortality was about 10 to 20%. We think 500 million people became ill with Spanish flu. About 50 million died worldwide, and about 675,000 people died just here in the US alone. Again, it spread across the globe primarily because of World War I. United States got into the war in 1917, so we dispersed it all across the globe. 1918, as you know, the World War I ended November 11th of 1918, or at least in Europe, it ceased fire, and then the rest of the world followed that. And as the war ended, the Spanish flu came to an end as well. The next one is 1957, Asian flu. Just quickly, it's an H2N2. It was first reported in Singapore in February of 1957, spread to Hong Kong and the United States later that year. We estimate about 1.1 million died, about 116,000 here in the United States died from that. A few years later, we had the Hong Kong flu, H3N2, similar neuraminidase, the N2 part. And again, we had about 1.1 million people die from that worldwide, and about 116,000 died from that in the United States. Let me skip SARS for a second. I'll put those in order. And the next one is swine flu. Now, I was an epidemiologist in 2009, and so we first saw this in 2 children in California who were diagnosed with swine flu H1N1. And because it was an H1N1, just like the Spanish flu of 1918, there was a tremendous amount of concern that this would turn into the Spanish flu. We'd have millions of people die from this. And so people raced to combat this. It raced around the world fairly quickly, and fairly quickly it was pronounced a pandemic. Now, the interesting about this was it was an H1N1, somewhat novel, and yet it had the same morbidity and mortality, the same death and illness rate as seasonal influenza, which was great news, but somewhat surprising. And so, that's the last flu pandemic we had. Next slide. Okay. I just want to briefly touch on SARS. I was an epidemiologist for the Florida Department of Health and was made the lead epidemiologist for SARS in 2003, along with a CDC epidemiologist. Now, I've wondered, does this look familiar to you? Because again, this is SARS, or severe acute respiratory syndrome is what SARS stands for. The incubation time is 2 to 10 days, as compared to COVID-19, which is 2 to 14 days incubation time. SARS had a total, I'll just tell you the end part of it now. SARS had a total of 8,439 cases in 29 countries with 812 deaths, or a 9.6% mortality rate. Something else I want to point out on this slide is the fever is the same as we look for COVID, 100.4, headache, muscle chills. One of the differences, this is a lower respiratory disease. Down lower, you have dry cough. COVID-19 is upper respiratory, so it tends to be a wetter cough. Next slide, please. Okay, so this is what happened. So I said I was epidemiologist in charge of this in 2003. We started hearing about this really more in February, about these respiratory illnesses in Guangdong province of China. February, the Chinese government said they'd had it under control and not to worry about it. But it was soon after that that an Italian physician, Dr. Carl Urbani, who was working with the World Health Organization, flew to China to investigate it and died on his way back from China. And that really obviously concerned a lot of people, that this was not what China was letting on it to be. It was much more serious than it looked like it might be. During this time, well, let me just go back a little bit. You should know severe acute respiratory syndrome with SARS. It originated in bats and went to what we think of as civet cats. Civet cats are wild animals. They look kind of like a cross between a big squirrel and a possum, but except they're very cute. Civet cats and all these other animals are sold in what we think of as wet markets in China. In Guangdong province, merchants are surrounded by living animals, and they butcher them right there for the customer, and they're just all around there. So there's lots of live animals, lots of blood, lots of different things, so that people are readily exposed to whatever the animal was infected with. And so, during February, a physician from Guangdong province of China traveled to Hong Kong to the Metropole Hotel, which you see here in the upper left, for a wedding. The hotel was packed, it was full. He attended the wedding, started feeling sick, and then flew back to the Guangdong province where he died. At the hotel were quite a few other people, obviously. Of this, 13 people contracted the SARS. What's interesting about this is some people, for reasons we don't understand, are known as super spreaders. They spread to a lot of other people, obviously. Other people can have the same disease and not spread to anybody, and other people can have the same disease, no sicker, yet spread to a lot of people. And so we think of this physician as a super spreader for reasons that aren't clear. So he spread it to over 13 people. These people ended up going back at the end to 29 different countries where they exposed people. And one of those people that he exposed was a 79-year-old woman, Mrs. KSC, 78, from Toronto, Ontario. She flew back to Toronto, where she infected 4 members of her extended family and ended up infecting a whole group of individuals there in Toronto. So it was quite a large outbreak there in Toronto. And she ended up dying as well. And the cause of death at the time was thought to be heart disease. Later they went back and tested her, and she died of SARS. And so again, 9.6% mortality rate. What we did here in Florida was we started tracking everybody that had the symptoms that you saw up there: 100.4 temperature, cough, tiredness, perhaps chills, malaise, other symptoms like that, and try to put them in quarantine. We followed up on hundreds of people here in the state of Florida, trying to get more information, testing on them. The final count, though, we only had 8 people that might have met the case definition here in Florida. The number was almost certainly less than that, but it was a probable case definition, not confirmed, because we couldn't get samples from everybody at the time. So if you look at this, you see the super spreader. One person can spread to a lot of people. The Metropole Hotel is on your right, and the bottom middle are clinicians, nurses, physicians, other people that were locked in the hospital. This is a hospital you're looking at, and they're begging to be let out of the hospital. What the Chinese authorities did when they found out that there were a lot of SARS patients in the hospital and they're transmitting to the clinicians, they'd lock the doors from the outside, barricaded, and not let anybody out of the hospital. And so these are people begging to be let out of the hospital to go back home. Next slide, please. So here's a clinical presentation for COVID-19. So incubation appears a little bit longer, 2 to 14 days. When I was in March and April, I was doing contact tracing in some of the counties around us, helping the county health departments by making calls to people and helping find out who was infected and then what to do about that. And I saw all of these symptoms as I was talking to people on the phone. It was interesting. Probably 30 to 40% of the people I spoke to had no symptoms at all, but they were COVID positive. Others, it's hard to describe, but they were, many of them had to be checked in the hospital, and 2 of them passed away from COVID-19. So it's a very serious disease. But one thing I want to point out to you that's such a critical difference. Now, both SARS and COVID-19 are both coronaviruses. Really 2 important differences. SARS has a much higher mortality rate, but is less infectious, so it doesn't transmit as easily. COVID-19 has a lower mortality rate, but here's the big difference. With SARS, you couldn't transmit the virus until you actually were sick, and then you started feeling sick, you're coughing, and that's when you transmitted. So people knew that they had an illness. With COVID-19, people often don't realize they're sick. They can transmit this virus long before they start feeling bad, before they realize how sick they are, they can be transmitting the disease. And that's why you often see people at parties having a great time and other people are infected because they didn't know they were sick until it was too late. And so that's one of the things I want to point out that's a really critical difference between SARS and COVID-19, even though they're both coronaviruses. Next slide. Okay, this is where we are right now with COVID-19. There are over 200 companies making COVID-19 vaccines that are in the phase 3 trial. A phase 3 trial is essentially asking, is this treatment that we're giving, this vaccine that we're giving, better than other treatments that are available? Are we improving the survival rate of these individuals who receive this vaccine? The questions about how toxic it is were asked earlier in phase 1 and phase 2. So it's believed that these are, they're not too toxic and will be beneficial. The question is, how beneficial are they? So there's a couple of vaccine companies here in the United States. I won't mention them all, but the interesting one is Johnson & Johnson has a vaccine. It's unlike the other companies, it's just a single dose, but it's a viral vector vaccine, which is really interesting to me anyway. They're using harmless viruses to deliver the vaccine, which the vaccine would just be proteins from the COVID. You can't get sick from this, but it delivers, these viruses deliver the vaccine to the cells, it replicates, and that's how the vaccine operates, which really is very innovative. They're using the same vaccine for Ebola, for HIV, for Zika virus. So it's in use barely, but it's a very new technology. I understand China is actually using insect cells to help grow their vaccine, which I've never heard of before. That's a pretty interesting idea. Let's see, what we don't know when it'll be available. Moderna in Oxford is another pharmaceutical company. They were just paused for a few days because they had an adverse reaction in one of their patients. And so that could happen to any of these, or it could be found they're not effective. And so this will all have to be analyzed and approved by the FDA, hopefully with no political interference and hopefully along scientific lines. Another don't know is, will COVID-19 become seasonal? And so in other words, coronavirus, or let me say it this way, 30% of colds are coronaviruses. And get colds and flus in the wintertime. It could be that COVID-19 becomes that sort of thing, where we just every winter, some people will get COVID-19 because it's just around, okay? We also don't know how long immunity will last, and this is true certainly for the vaccines because they're in development. Will these vaccines last a lifetime, 6 months, 2 months? We don't know yet. The associated question to that is we don't know how long immunity lasts for somebody that has COVID and has recovered from that. So there are reports of people that had COVID multiple times, people that had it 2 months after they had the first time. And so we're trying to figure that out. And that's a really critical question in terms of thinking about herd immunity. I don't know if I have time to talk about herd immunity, but if I do, I'd love to talk to you about why that's a bad idea and why we need to not go there here in the United States. Other countries have tried it, it hasn't worked out, and I'd love to talk about that if we have a second. And then the fourth question is, who will receive the vaccine once it is available? And I know it seems like a simple question, but it actually is very complex. You might think clinicians, nurses, physician's assistant, physicians, respiratory therapists, and that's probably true that those people working with COVID-19 patients might be first in line to get that. You might also think, well, what about vulnerable populations, the elderly, for instance, or pre-existing conditions? Perhaps, and it depends on how many vaccines are available. But emergency planners spend a lot of time thinking and arguing about this, and sometimes you have to think kind of outside of that and think, well, what about truck drivers? And the reason truck drivers come up in discussion is without truck drivers, food is not delivered to your grocery store. And if food is not delivered to your grocery store daily, or at least every other day, the shelves are bare. As all of you have seen after hurricanes, just after one day, the bread aisle, all that stuff's cleaned out. So without truck drivers, there's no food, and that's a serious problem. Perhaps grocery store workers as well, also utility workers, pandemic or not, we still need electricity, we still need our sewage to work, all that has to work. And so these are complex discussions about who will get the vaccine first, and it really is based often on not just importance, but how much vaccine is available. Okay, next slide, please. So what can we do? Now, I apologize. I know you've seen this 1,000 times, social distancing, wearing masks and washing hands. They really do work. They really do. We've been doing this for decades. If you look at pictures from 1918 Spanish flu, they were wearing masks, they were washing their hands, and they're trying to socially distance. So that works, okay? So please, and this is not about me or you, I don't want to get somebody else sick. I don't want to get a family member sick. I don't want to get a stranger sick because I unintentionally infected them. So that's why I try to socially distance. That's where I always wear a mask around the people. And that's why I wash my hands. But something that you might not have considered is other things like 8 hours of sleep or enough sleep, I'll say. People require different amounts. It has been proven that getting enough sleep strengthens your immune system. You will be healthier if you get enough sleep. You'll feel better, your immune system will be stronger. Similarly, nutrition, eating the right foods helps strengthen your immune system, makes you more resistant to disease. Now, it's hard to tell you what proper nutrition is sometimes, but we all agree what proper nutrition isn't. So if you're eating macaroni and cheese 3 times a day, you may want to broaden your diet a bit. The next one is consider eating fewer animal products. I'm not a vegetarian, but I do realize that part of this is because we're eating so many animal products, there is a fantastic environment in which for these viruses to grow and to transmit their genetic material between chickens, ducks, pigs, all these domesticated animals that are then butchered and then passed all around the country. And so just something little like eating fewer animal products would actually make us healthier, would probably decrease the number of pandemics that we will have. You heard me say that we will have, because we are going to have more pandemics. The next one is wild habitats. You know, something that we're all familiar with that you've heard many times is Lyme disease. And that's because you're going out into the woods, and this is something I do a lot. I hike and camp, but you may want to consider being careful about using insecticides so you're not bitten by mosquitoes and you can't get West Nile virus or Eastern equine encephalitis, or in other countries, malaria or dengue. But here in this country, you need to make sure you do a tick check after you've been out in the woods to make sure you don't have any ticks. So you can't get Lyme disease, you can't get Rocky Mountain spotted fever, you can't get ehrlichiosis, you can't get these other ones that are so important. And China has tentatively agreed that they need to have either fewer wet markets or control those. And again, the wet markets where all these animals and people are crowded into small areas, that we saw SARS arise from that. So again, civics, it was bats, civet cats, humans for SARS. For MERS, which is Middle Eastern Respiratory Syndrome, which is also a coronavirus, it was bats, dromedaries like camels, and humans. That's over in Saudi Arabia and Kuwait currently. And then for COVID-19, it's bats, and we're not really sure what the intermediary host is. I've heard pangolins, I've heard different animals, but we don't know yet. For SARS, they originally thought it might be snakes, and that was disproven. So we're still finding out about that. And then lastly on this list is be careful with international travel. You know, I don't know what that means for me, but for you, just you want to be careful and be alert for health warnings. Next slide. Okay, the new normal. Well, I'm going to be optimistic and say summer of 2021, that maybe we'll be back in class fall of 2021. Please don't hold me to that. A lot depends on how responsible people are with wearing masks and social distancing and the vaccine. And I don't have control over those things, but it is possible if we're responsible citizens that could happen. Again, COVID-19 may be a seasonal event. We may see this every year. Next summer, I would throw away your mask. You may find that you need to keep using that. So keep it handy. Maybe invest in mask stock of some kind, because we're going to continue. Business routine will be reexamined. What I mean by that is, you already know our educational routines have been altered. Most of us are online. We're not able to spend as much time together in class. Well, that's going to change for other businesses as well. Office workers aren't going to automatically assume they have to be in an office to do work. That they realize that a lot of work can be done off campus. Lawyers I've talked to say maybe they don't need 2 floors of really expensive real estate, that maybe just some offices and a few conference rooms will be satisfactory for them, and they can do a lot of the work elsewhere. And so there'll be a lot of those changes societally as we get used to this. And the last one, social habits may change, at least temporarily. And what I mean by that is it's a lot of things that we're now experiencing. It may be that handshakes don't come back, that we may just permanently stop shaking people's hands. You know, I hope hugging doesn't go away, but there's some things that we may want to alter, and maybe big crowded rooms might be one of those things. Maybe offices with the cubicles, that may go away. So we're gonna have to see what that means exactly. But I think there's be a lot of changes as a result of COVID-19, and most of them I think will be good. It's hastening us toward the future in many ways. Okay, next slide. Okay, I just put this in here just as an example of zoonotic diseases. You might have read like Joseph Conrad's Heart of Darkness, where he's in a river in the middle of Africa and he dies before he can reach civilization. Well, those days are over. And so now you can be in the deepest, darkest parts of Asia, South America, Africa, Arctic, or the bottom of Grand Canyon, and you can be back at Hartsfield International Airport in just a matter of hours. Less than a day, you can be back at a major airport. If you think about COVID-19, you can be hacking and coughing but not really realize you're sick. And so you could be transmitting that as you stand in the hallway of Hartsfield International Airport, people going all over the world walking right in front of you or on an airplane. And so this is something that we're going to continue to struggle with. And this is just one of many reasons why we have great concern over pandemics in general and over COVID-19 specifically. That's all. Well, the final thing I want to say is, if you're looking for more information on this, I guess a couple of things I recommend. A book for books, an older book now, came out in the late 80s, I guess it was. Mid 90s, I guess it was, called The Coming Plague by Laurie Garrett is a good book. Another one called The Hot Zone by Preston. It's really pretty. It's pretty gory in many ways, but it's an excellent read about the true story about how Ebola was discovered and the impact it had on the local population. It's a great book. And then a movie is Contagion that came out a few years ago. It actually is pretty prescient about how a pandemic would look and act. And so you may, if you're interested in that sort of thing, Contagion is pretty good. I don't know how much time, am I out of time? Should I start taking questions now, or do you want me to keep talking?
We do have a few questions if you want to start taking questions, but
Yeah.
if you wrap up, we have maybe 5 more minutes before we can wrap up.
Yeah, happy to take questions.
It's entirely your choice if you have any closing thoughts, and then I can ask you the questions we have been getting.
Okay, well, it's one quick closing thought. Herd immunity, this is one of my pet peeves because people have heard this term herd immunity, but if you think about, I'll go through this quickly, I don't want to take up too much time, but if there's 1% mortality with COVID-19, what that means is 1% of, say, Americans would die. That's somewhere over 3 million people conservative would die. And so, and here in Florida, it'd be what, 200,000 people would die. Ethically and morally, that is just difficult to believe that we would accept that as just putting up with COVID-19 to try to get over and get our economy going. So that's one issue. And the dead is actually not the greater problem. The greater problem are those that become very sick. They would quickly overwhelm our medical system, and more clinicians would become ill. That means that, and people that had illnesses besides COVID-19, like burst appendix or a car wreck, would then have a high mortality as well, because the hospitals and medical systems are overwhelmed with COVID-19 patients. And the third and last one I alluded to earlier was immunity. We don't know if how long people have immunity to COVID-19. It could be that you have COVID-19 and then 2 months later you have it again, which means that even if you decided to go with herd immunity to protect your population, it wouldn't work because you'd keep getting it and you'd keep transmitting it to other people. So for that reason and other ones, I'd like to put that to bed, that is just not an acceptable strategy. Sweden's the only country in the world that try to do that, and they're a much very, very different country than the United States, and even they are struggling with that and questioning that as well. So that's all I want to say. Thank you so much, and please, can I have any questions?
Thank you everyone who has been sending us questions. Please feel free to send them to me or to Laura Dean. We do have quite a few actually, and I'm going to try to triage them in many ways by grouping questions that were very similar. So Kristen and Neil both asked this question about early on about other pandemics that we have had. So Zika or HIV, for example, are both pandemics. Why were they not on your list?
Yeah.
If you could tell us a bit more about that.
Yeah, so as I mentioned about HIV, HIV is considered a global epidemic for reasons that are pretty complex. I think, frankly, my opinion is the first article on HIV was a 1981 article in the Morbidity and Mortality Weekly Report by the CDC, and the title of that article was Pneumocystis pneumonia in homosexuals in LA. And so HIV has always been treated differently than every other disease, and that's a terrible thing in many ways, but I think that's one of the reasons that contributes to that as a political as well as financial decisions for that. Zika has traveled from, I have information on that, but it's from Africa over to South America, Central America, now to the US. There's vaccines for that. It is technically a pandemic, but it's considered more part of a group of zoonotic diseases called arboviral diseases, along with triple E or Eastern equine encephalitis, St. Louis encephalitis, and Venezuelan equine encephalitis. So it's considered more of a group. And the reason for that is because the way to combat that is the same for all of those. So instead of breaking Zika out separately, it's thought of as a group. Currently, right now in, excuse me, in I think it's Wisconsin, they have a fairly large Eastern equine encephalitis outbreak. And so it's not generally, what the list I gave you is what everybody agrees on as a pandemic. Those are not completely agreed on that that's a pandemic. Certainly Zika alone does not meet that that level.
The next one is a two-part question, and it says, in your experience, how does potential population resistance to adopting a vaccine differ in these times as compared to public health outreach in past pandemics? Are there any hopeful strategies for a wide adoption under these circumstances?
Yeah, no, that's a great question. This is my pet peeve. I'll tell you, I get hot and bothered by this. So, so a couple of decades ago, oh, I forget his name, Andrew Speakman, maybe. A physician in England had like 12 children that was totally fraudulent, and from that anyway, he wrote a paper saying that Andrew Wakeman, that's it, that Wakefield, that children that are vaccinated have autism. You've all heard that on the internet and other things as well. And so there's been this anti-scientific movement against vaccines in general. The thing is, our grandparents, great-grandparents, they grew up in a time when people were dying of measles, mumps, rubella, of things that we completely can vaccinate against now. And so this was a miracle drug for people 50, 60 years ago, just like antibiotics were. It was a miracle drug. And so now we've become so comfortable with this that we forget that people can die from measles. And so so they decide, well, I'm fearful of something that is scientifically incorrect, that some vaccine can cause it. And that's been, by huge, massive studies, shown to be false. It does not cause autism. The vaccine doesn't. The schedule of vaccines do not cause autism or any other disease. What it does is a measles vaccine prevents measles, which is extremely infectious and can kill children, along with, like I said, measles, mumps, and rubella as well. So it's important that people get their vaccines. So what we have to do is start educating people and getting rid of these false narratives, the conspiracy theories, and educate people on the benefits, because what we don't want to see is young children die of very preventable diseases. That's a tragedy. And so that's what we need to do with this. And part of it is currently, and just be straightforward, is we need to make sure the process for COVID-19 is scientific and there's no perception of politics in the approval of whatever vaccine comes along, that it's been approved by standards that we've had for decades, and there doesn't seem to be any other interference in that process. And that's what we need to do.
That's really,
thank you for that question.
Yeah, it's a great question, and it's really good advice too, because we tend to forget the civic duty portion of why we need to science. I do have several other questions. Some of them are more about the technicalities of COVID-19 itself, so I'm going to ask you those questions. So for example, one of the questions that were brought up was, how do COVID-19 antibodies work? If you could talk a little bit about that. And also, what is the impact, long-term impact of COVID-19 on your body? So these two questions are kind of grouped together.
Yeah, I'm not sure if the antibody test is talking about how the vaccine works, or if it has to do with the antibody test. good question. The antibody test, I'll just talk about that for just quickly, is in the past has not been very accurate, a lot of false positives, a lot of false negatives. It's getting a lot better now, and it can be a really helpful tool to determine your vulnerability to becoming infected by COVID. I'm sorry, what was that second question again?
The second question was, are there any long-term side effects identified for COVID-19 patients?
Yeah, so that's an interesting question. One thing that makes COVID-19 interesting for me is that there's a lot we don't know. And so we're still finding this out. Remember, COVID-19 has really only been around since the beginning of the year. So we're still finding out about it. But yes, what we found out so far is that we thought that COVID-19 earlier was a pulmonary disease, had to do with the lungs and bronchi and other things. What we're finding out now that it actually is more of a vascular disease. It impacts many of this, well, all your systems. It can impact all your systems. And that's why you hear people having legs amputated and fingers turning black and parts of their face turning black, is because it's not just lungs. It's also has to do with your vascular, your circulatory system. And so long-term effects have been loss of circulation and actual amputation from this. We're seeing cognitive interference, and we don't know how long-term that is, but people that are having trouble keeping their thoughts, they describe themselves as scattered, they can't concentrate. And so again, we don't know how long-term that will be, but it can be a serious long-term effect. And those, again, death is an end result, and it can be tragic, but often these illnesses that go on for weeks, months, and longer can be devastating, not just for the individual, but for the healthcare system and healthcare finance as well. So there's tremendous impact of these long-term problems from COVID-19. Thank you.
Thank you. There are a few more questions just about the ability or the scope of how COVID-19 spreads. Dana wants to know, what is the impact on the ability of COVID-19 to spread when you are outdoors? So if you're on a beach vacationing with your family, what are some things that could happen, and how could it spread?
Okay, great question. I can tell you, I'm into outdoors, and so I just believe that if you're outdoors, you're fairly safe. Now, if you're outdoors with 100 people around you, that's not the case. But if you're outdoors and you're 6 or 10 feet away in the sunlight, and if it's kind of breezy, I believe you're fairly safe. And why I say that is, it's not one COVID virus that gets you sick. You generally have to have, we don't know exactly, but hundreds, if not thousands, of the virus to come inside of you to make you sick. And so if you're by somebody and they're 10 feet upwind from you and you inhale a virus, it's probably not going to do anything for you. Also, UV radiation from the sun. These are generally fairly wimpy viruses. They can't last for 24 hours outside in the sun. They last usually probably at most hours in the sunlight, probably much less than that. So if you're outside on a beach, walking with your family in the woods or other people, you're probably going to be, bicycling is another great example, you're probably going to be pretty safe. And I think, with everything, there's a cost benefit analysis, and it is deleterious to hang out in your room 24/7. I get that. So I encourage people to go outside, go in the woods, go biking, go running, go just, the parties I've seen in Tallahassee where there's hundreds of people in a little courtyard, not a good idea. But otherwise, when you're out with some friends, you're walking kind of spaced out in the sun, in the breeze, I think you're going to be fine.
There are questions along the same stream. So I'm just going to group them together. Sarah and Annette ask if, how risky is it contracting COVID-19 from delivery services such as food or online shopping? And what is the risk profile of traveling by airplane?
Yeah. Okay, so I order stuff from Amazon all the time. And so I think they're pretty safe, personally. And so I don't worry about that. I used to, honestly, I kind of panicked a little bit early on. I wiped down my groceries, and now I don't do that anymore. What we find out is that it doesn't live well on things. And again, you have to have a number of viruses to really inhale. It doesn't seem like the alimentary canal is a good exposure source. So if you put it in your mouth, probably now if you wipe your eyes, your nose, that's a bad idea. But if you get your groceries, go shopping, and wash your hands well, you should be fine. So I wouldn't worry about delivery services, including food. Again, just have some common sense. You may want to be somewhat careful handling things and just use common sense. So if it looks grungy, don't eat it. But in general, I think it's fairly safe. Airplanes, that's a different thing, obviously. In my opinion, we're still finding out about this. My opinion, the airport is actually more dangerous than the airplane, assuming you're wearing your mask. And the reason for that is airplanes actually have a pretty good ventilation system. And so I would encourage you, as soon as you get on, crank open the vent so it's blowing down you, so the fresh air is coming in, and then everything's going away from you. So there's a flow of air. Personally, I'm not going to fly an airplane for quite some time. It's my choice. I don't encourage people to fly. But if you have to fly, wear a mask and don't touch anything you don't have to touch. And certainly after you've touched something, don't touch your eyes, nose, ears, or mouth. Just keep it away from there. And by the way, gloves, don't wear gloves. They're a bad idea. Just wash your hands a lot, but don't wear gloves. Thank you. Good question.
That's good advice. I certainly remember ordering a bunch of gloves right when the pandemic started. Just because that was something people were saying to do.
Right.
And I'm glad I stopped using them very quickly.
Yeah.
The next set of questions are a lot to do with vaccines and vaccine trials. So again, I'm going to try grouping them together. And one of the questions that comes is from Dylan, and he's asking how you personally feel about trials testing to see what drugs are useful in relieving symptoms. So hydrochloroquine, remdesivir, there's so many experiments going on. What is your feeling about that?
Okay, let's see, what is my opinion about that? Yeah, so, okay, so let's back up a little bit. So I used to work, like I said, for the National Cancer Institute. We do investigational drugs, let's see what's efficacious. And so, the first thing was a hydrochloroquine, and the problem with that, it's not a question if somebody gets better when they take hydrochloroquine. The question is, do they get better faster or easier than another group that also has the disease? So we're comparing, efficacy between one group and another group. You think of cases and controls, for instance. And so, so far, there has been a mix on that. Hydroxychloroquine has not been shown to be efficacious. Others are showing to be helpful, including certainly steroids that you mentioned, and some other ones. It needs to go through some trials, and these don't have to be extensive long-term trials, but they can be fairly short. Phase 1 is it safe? And that's what every drug should go through before we start injecting it into humans, is find out, is it safe or not? The second part is, does it work? And then the phase 3 is it better than what we're already doing? And so be careful. I've heard so many treatments that are offered on magazines and online. Just be very careful what you inject inside of you. It can be dangerous, and I would go with what your physician prescribes and kind of where the science is leading us. I haven't heard anything that's outside the emergency room or in the hospital that's all that effective, other than, I'm reluctant to say this, but I will, there have been indications that vitamin D can be helpful in preventing the illness. There's no data that suggests vitamin C, but it doesn't hurt to take those things. There has been some information, like I said, that vitamin D might be beneficial, but in general, back to my earlier point, good nutrition. Mm-hmm. Thank you.
Another question is from Susanna, who's asking about contact tracing apps. And she wants to know if you believe contact tracing apps are useful, why are they useful? If you could talk about that.
Yeah. So as I mentioned, I was a contact tracer for the Department of Health over in the rural counties out to our south and east. Uh, well, let me back up a little bit. Contact tracing is very beneficial if you have an outbreak, an epidemic that's growing or expanding, or the opposite side of that is decreasing. So you can really prevent further infections. At some point, it's less effective because you have so many people, it really becomes a societal issue where everybody needs to start, I'll say, behaving, which is social distancing, masks, and all that. The software is helpful in a number of ways, though. Often it educates. It's not just checking in. It's not just where are you? Are you quarantined? Are you isolated? But actually, in my opinion, a more important aspect of that is educating people. It's, are you wearing your mask? Are you social distancing? Do you, and the calls were often, well, this happened. Should I be concerned about that? I've been around this group of people. Is that a problem? And so education is perhaps just as important as some of the apps are. And this is still kind of a nascent technology. In the past, you'd go house to house, knocking on doors, to be safe. Now it's a bigger thing with, social media and all that. So we're still figuring out some of this, but yes, I do think it's beneficial. I think it's helpful, but it's more helpful at the very beginning and toward the end of a large epidemic or pandemic in this case. Thank you.
We have a question from Tisha, who is asking, what are your thoughts on campaigning or door-to-door canvassing and COVID-19 exposure as we are nearing elections?
Yeah. Okay. Yeah. Great question. Again, it really comes down to the basics. For instance, canvassing, wear a mask, social distance, and that should be protective. I don't expect, and you're going to have large groups anyway. So you're going to have one or two people at a door, one or two people in the house or wherever you are. So if it's smaller numbers, I don't think you have to worry too much about that either. The other concern, of course, are elections. There's a lot of mail-in balloting, but I know a lot of you want to go and cast your vote on November the 3rd. Same rules. Try to social distance, try to face mask, and also eyeglasses. Eyeglasses have been shown to be very effective, kind of like the shield that you see professionals wearing. Eyeglasses keep droplets from getting the eyes. That's one of the main portals, along with the nose, of entrance into the lungs. So that sort of thing. I voted in person for the primaries, and when I was there were like 3 people in the whole, 3 voters in the big, huge fellowship hall, and about maybe a half dozen workers, and I never got within more than 4 or 5 feet of a worker. So I thought that was managed well. So I felt fairly safe voting in person, but I think if you're smart, you can do the whole process safely.
Dr. Rowan, we do have a few more questions. Do you mind sticking around another 5 minutes and answering them?
Not at all. No. Whatever. If I can answer them, I'll try.
John is asking, and I'm sorry, John, I'm coming to your question just now because it's really summative in many ways. And John is asking, are there trends that have emerged from countries with different types of healthcare systems? For example, universal healthcare. And are there certain types of systems that tend to do better than others when it comes to pandemics?
Yeah. Great question. Okay, wow, that's a great question. I'm trying to think of a reasonable answer to that. So all the countries except perhaps the United States have universal health care, and we kind of have one. And so those countries are healthier. United States rates about 33 in our healthcare system based on many important measures. And so those countries tend to be healthier to begin with. And the other issue is we have to consider not just your health at the time that you're sick, and I realize that sounds kind of odd, but the main #1 cause of bankruptcies in the United States is healthcare bills. And that doesn't happen in other countries that have universal health care. You don't have to worry about going to the emergency room, going to the hospital. then having a $200,000 bill that you have to pay. And what that does is people don't wait to go to the emergency room if they need to. And that's really important. Or what people here in this country often do is they wait till they're really sick and then go to the ER. It would be better if they went to the primary care physician or other places sooner as opposed to waiting until they're really sick. So those are important. So the financial impact, you're healthier up front, and then you get treated sooner if you know you have coverage and know that you won't go bankrupt utilizing that coverage. In other areas, and this one, we find that people do better in other countries. And so places like New Zealand, Australia, Germany, Japan, who have a similar system, healthcare system to each other, they have a lower number of cases, and better outcomes for their patients who have COVID is what we're seeing. And although they have had spikes, their spikes, I can't show you, but their spikes are down here south, and our spikes are way up here in the United States. And if you look at the rates, by the way, Johns Hopkins University has a good website. We are going at 45-degree angle up here in the United States, and over 20 of our states are increasing at high rates right now. So we've got to do something to decrease this, or it could get much worse as cold weather sets in and more people are inside. Thank you. Good question.
We're talking about comparative systems, and Elchin is asking that going back to the question of vaccine trials, there are a low number of people of color signing up for vaccine trials. Why is that important as we try to find a cure for COVID-19?
Wow, that's a great question. Thank you for that. Okay, so I remember back many years ago, it was, children were thought of as just small people, but there's differences, and we need to make sure that everybody's represented in these vaccine trials, because SES makes a difference, and so we need to make sure that these trials represent United States of America, which what that means is all populations, all demographics, including Native Americans are not represented in these trials either. And that's really not just ethically a problem, it's efficaciously a problem, because we don't know how it will impact these populations. And it's critical. And the NIH and FDA have taken some criticism for not making sure that more people, minorities, and other people are enrolled in these studies, so we can find out how it impacts them. Is it the same as, a white 50-year-old male? And the answer is probably not, but unless they're enrolled in the trial, we don't know that. And so we've got to do better at finding answers to those questions and making sure that the trials, particularly the phase 3 trials, are representative of the population upon which the results will be generalized to and applied to, in this case, the vaccines. That's a great question. And the answer is, honestly, a lot of it's historic. I mean, we've been doing these trials in such a way, and it's hard to reach out and make sure we enroll other people. And it starts with the healthcare system. If they're not in the healthcare system, there's a very high likelihood they won't be enrolled in these clinical trials either.
Dr. Rowan, our last question is about the spread of COVID-19 again, or the spread of generally these pandemics. And Kevin is asking that most viruses tend to be generated through bats. Why is that? Why is this particular animal so important when we look at infectious diseases?
Yeah, that's a great question. Bats are very cool, by the way. I love bats. They're just amazing creatures. So I'm not a bat expert, but as an epidemiologist, what I understand is that bats operate at a much higher temperature. And so the viruses apparently don't impact them. They're not affected. They don't get sick from these viruses the way we do. And that's all fairly new. And we're still finding out why bats are so cool. But that's one reason they're cool, is that they can have all kinds of viruses, bacteria, and not get sick from it. These caves that have bats in it are just ripe with bacteria and viruses and fungi and all that. They're just amazing places. So it's thought because of their high temperatures, they're not affected by this. The other thing that happens is these viruses, The best example, let me take influenza as a great example. Influenza is thought of as a promiscuous virus. That means it gets around. And what that means is it takes a genetic material from not just what it has, but it's more than happy to swap genetic material with pigs or chickens or other things and bring that in. And so now you can imagine if it has pig RNA, it can now talk to our genetic material, and so it's easier to get us sick as well. And so that's part of that whole system. We aren't in contact with bats very much, but the bats are in contact with certain animals, and then we're in contact with those animals. So that's the kind of chain of transmission there is they don't get sick, but that doesn't mean the animals they come in contact with humans will get sick. That movie I mentioned, Contagion, actually, that's what the whole movie's about. I don't want to give it away, but anyway, they talk about some of that. But the bats they're throughout, and it's bats both in well, a lot of rabies, of course, but also in the SARS, in the COVID-19, but as I mentioned, also in the Middle Eastern Respiratory Syndrome, which is also coronavirus. It's also bats, and then some intermediary animal before it gets to humans.
Mm-hmm.
So great question. Thank you.
I think you're perhaps the first person who has told me bats are cool. But
oh, yeah, no, bats are fantastic. Thank goodness for them too. They pollinate, they eat insects. They're great.
We should talk about that in another Engage Award where you just talk about bats and why they are cool. I think that would make a great lesson. But I believe I asked all the questions that were sent to me through the chat feature. But Dr. Rowan, I want to thank you for joining us today and really educating us on how pandemics work, even with just clarifying small things. For example, I know going outdoors is great and it's just a safe way of being in this time, but just hearing it from you, I feel encouraged to just hop out right now and go hike a little bit. So I really appreciate you coming
Absolutely.
and it down for us in a very simple manner. If you do have questions for Dr. Rowan and did not get a chance to ask them now, feel free to email us. We'll be happy to direct the questions to him for you.
Yeah, absolutely.
The talk was recorded, and we're going to arrange some ways for you to get the talk in case you want to come back and listen to it once more. Thank you so much for being here with us. If we could have a round of applauses for Dr. Rowan for joining us today, I would be really appreciative. And
thank you.
Please check the CGE website for more Engage Your World events. Thank you so much.
Thank you.